Just putting a timer.
No problem.
All right, my name's Davis Delanchian, and my topic is on the overprescription of pharmaceuticals. It's my belief that doctors within the United States are overprescribing pharmaceuticals in dangerous quantities to the United States populace. Overprescription is defined as the prescription of useless drugs or the prescription of effective drugs in dangerous or unethical quantities. A pharmaceutical is a compound with healing or medicinal purposes. So there are three areas in which I believe majorly contribute to this overprescription epidemic, and that's the area of antibiotics, the area of narcotic painkillers, and the area of antidepressant SSRIs. So, according to the CDC, which is the Center for Disease Control, a federal agency, antibiotics have no effect on viral infections. So viral infections are something like the flu or common cold. Despite this, also according to the CDC, 1 in 3 prescriptions for antibiotics are for viral infections. So obviously doctors should know that antibiotics don't affect viruses. So why does this happen? Doctors often have to see a large influx of patients on their day-to-day, and you can't get through each patient if you have to explain to them what an antibiotic is, what effects it has. So a lot of doctors just go the easy route, and they just give them an antibiotic anyway, and just assuming nothing wrong will happen. But once you prescribe antibiotics on such a large portion of the population, this gives bacteria a chance to test their evolutionary fitness against it. So they can test themselves against the antibiotics, and eventually they'll be able to overcome it or become resistant to it. And once this happens, you have diseases that are just like viruses. There's no quick cure for them anymore. So once you have salmonella, you have salmonella. You can't take a pill to get rid of it anymore. The second field of narcotic painkillers, according to the CDC, according to their regulations on dosage for painkillers, 99% of doctors within the United States are overprescribing. So they're either giving pills for too long a period, or they're giving pills that are too powerful for what the patient needs. According to an article by the New American, 38% of adults in the United States take some sort of opioidal painkiller. And because of this, the population, a percentage of the population that is essentially addicted to some sort of painkiller has gone up dramatically. And even if it's very difficult for doctors to deny their patients some sort of relief from their pain, because that's the doctor's sort of internal drive to help people. So even if they're to overcome this and do the correct thing and not prescribe painkillers when unnecessary, patients can go from one doctor to another, finding one that will eventually give them what they need. This is called doctor hopping, according to the New York Times. Finally, in antidepressants, according to Psychology Today, most family physicians aren't well equipped to deal with psychological problems. So when a patient comes to them saying that they have some sort of depression issue or bipolar issue, doctors aren't well trained in those regards. So they take what they're hearing for face value, or they're misdiagnosing and giving the wrong prescription. So a lot of people are getting the wrong treatment. Most people would be better suited for therapy than they would be for some sort of body chemical altering substance. Often there are underlying problems that are due to the patient's lifestyle and not their chemical composition. According to Psychology Times, as of 2014, SSRI use, which is the main form of antidepressant, had gone up 400%. And that is an old statistic, 3 years old at this point. So it's likely gone up more than that since then. When patients get these pills, often it doesn't help them, because sometimes they don't even have depression. Sometimes bipolar disorder is misdiagnosed as depression, and vice versa. In fact, most of these prescriptions that are given out by family physicians, under the DSM-5, which is the standard of psychiatric medicine, it defines what psychiatric disorder is what, and what the boundaries are between each disorder. Most of these diagnoses don't even fall under depression. They don't fall under major depressive disorder. So because of this, many Americans have been given prescriptions for a disease they don't have, or a disease that is is different than what their doctor thinks. So overall, it's within the fields of antibiotics, within the fields of painkillers and antidepressant medication, I believe doctors are going the easy route and not helping patients with the care that they need by just giving them the easy solution, giving them one pill, and letting them fend for themselves. Thank you.
I'm so free.
All right, Davis, it's pretty well organized. The secondary points, though, are not really labeled as claims. They're just topics, and so you could be much more specific about the inference that you're drawing on each of those points, although I think the audience will probably figure it out. Your proposition is clearly stated at the beginning, and so it just doesn't seem right that the secondary points aren't also labeled as claims as well. Even though it is well structured. So I appreciated the effort there. Need to make step it up a little bit to make sure that the claims follow on the supporting points as well. The evidence that you have, there's evidence on all of the points. Sometimes the evidence, though, seems to be a little bit underwhelming. Like on the whole issue of antibiotics, there's not really information that talks about how the antibiotics get, the bacteria build up a resistance to it, and it creates a potential problem. I think people are probably a little bit aware of that, but you've got no information to support it. The information that you do have, it talks about how the antibiotics are prescribed frequently, and I thought that that was pretty reasonable, that people are getting these things and they're getting them for viral infections that they don't do any good for. That's solid. But the relationship, for instance, to the prescription there and then the development of bacterial resistance, I think needs to be a little bit stronger. And the follow-up, I think, is where your argument is, and that's where there was less evidence than there needed to be. On the narcotics issue, I thought that you had pretty good information about the frequency with which these painkillers are prescribed. There's not really much information about whether or not people actually have that pain. The information that you do have suggests that they are getting the painkillers for too long, or they're getting dosages that are too high. That's your explanation there. The proof on that, I think, is a little bit thin. The only thing that you have is the percentage of the population that is taking those kinds of painkillers. 38% seems pretty high. I mean, that's basically 4 out of 10, and I'm tempted to just do a survey right here. How many of you are taking an opioid right now? I'm not going to do that, but it just seems like maybe there's a context for that. Maybe there's more information. Sometimes what happens is when people get information, they look at the statistic and they're paraphrasing it and the way they think it means. I think maybe you want the direct quote there as a way of addressing that issue. And again, I'm not saying that it's not true. I'm just not sure that it sounds correct, and it would be so much better if you have the direct quote. Then there's probably no doubt about it. The idea of doctor hopping, I think that's you explain that. You've got a quote on that. I'm not exactly sure that there's anything controversial about that. The third point, that the doctors aren't trained adequately for the antidepressants, I thought that was the one that you had the clearest argument on. It's pretty well developed that the doctors might not have the ability to either diagnose these sorts of things, or that they're misdiagnosing these sorts of things. But I think you need some information that shows the doctors are prescribing these things. That's the stuff that's missing, that they're undertrained. I thought you had some information on that, but there's a lot of stuff that's also asserted on those points that needs to be developed. You did a good job speaking to the audience, very solid and confident while you're talking to us, and so even if you sometimes are giving us assertions, you're doing so in a way that probably would be persuasive because of your ethos. All right, thank you.